versus non-pulsatile flows, anticoagulations on CPB, and non-cardiac indications of CPB. Introduction. The primary function of cardiopulmonary bypass is to divert blood away from the heart and lungs and return it to the systemic arterial system, thereby allowing cardiothoracic and vascular surgeries. Therefore, it must replace the function of both the lungs, that is gas exchange, and the heart to provide circulation of body by giving bloodless field for surgery. Cardiopulmonary bypass provides this by incorporating a pump to substitute for the function of the heart and a gas exchange device, the oxygenator, to act as an artificial lung. History of cardiopulmonary bypass. In 1812, Lee Galois showed that extracorporeal circuit is possible. Part of the body might be preserved by sort of external perfusion device. In 1858, Brown sequenced arterialized desaturated blood. He used syringes for perfusion and put oxygen into the dark venous blood by beating the blood vigorously. An interesting observation he made by temporary disappearance of the rigor mortis of muscle of glutinide uh, animals when they were perfused with their own blood. In 1882, first bubble oxygenator by von Schroeder bubbling method was based on supposition that bubbles of a gas such as air or oxygen passing through blood would become surrounded by a thin layer of blood that in turn would absorb oxygen, give off carbon dioxide, and then burst and leave the blood free of gas. In 1885, first film type oxygenator filming method, it is best technique for oxygenating the blood, the one that would form the basis of techniques currently in use. Bonfrey and Gruber achieved this objective by dispersing the blood as a thin film inside a rotating slanted cylinder filled with oxygen. In 1890, Jacob J. described on device with a bubble oxygenator and bladder pump in order to provide pulsatile flow, oxygenating the blood with a mechanical device altogether by accomplishing this objective through the use of the animal's own lung. In 1916, discovery of heparin by MacLean's significant step in evolution of heart-lung machine. In 1928, Dale and Skister described the prototype pumping mechanism, that is valved pumps. Now, birth of the idea of CPB. In 1930 in Boston, Dr. Edward Churchill, who saw a female patient post cholecystectomy at once in a consultation and found her frightened, pale, cyanotic, cold, and moist. So, John H. Gibbon Jr. was assigned the task of watching the patient and monitoring her vital signs throughout before surgery. He believed that the diagnosis of massive pulmonary embolism. She was moved to the operating room where pulmonary embolectomy was done. So this idea naturally occurred to him that if it was continuously removed some of the blue blood from the patient's swollen veins, put oxygen into that blood and allow carbon dioxide to escape from it, and then inject continuously red blood back into the patient arteries, we might have saved her life. We would have bypassed the obstructing embolus and performed part of the work of the patient's heart and lung outside the body. So Gibbon planned to build an apparatus with the oxygenating capacity which permits safe total CPB in humans. Gibbon later estimated that if this objective were achieved using the rotating drum technique, Dr. Gibbon hence considered as inventor of a cardiopulmonary bypass machine. In 1935, he maintained a cath circulation on CPB while closing the pulmonary artery. In 1955, at Mayo Clinic, Gibbon heart-lung machine, that is screen oxygenator plus roller pump. This model was used in first series of open heart operations performed by Dr. John Kirkling and Associates. Dr. F. John Lewis on September 2, 1952 in University of Minnesota successfully closed a secondum atrial septal defect in a 5-year-old girl under direct vision using inflow stasis and moderate body hypothermia, that is 26 degrees Celsius. Azygous flow principle. Morley coined during some canine experiment in which the cava were temporarily occluded to test tolerance limit of the brain and heart to ischemia. It was discovered that if the azygous vein was not clamped, the resulting very small output, cardiac output, that is 8 to 14 ml per kg body weight per minute, was sufficient to sustain the vital organs safely in animals for a minimum of 30 minutes at normothermia. Previously thought that the basal cardiac output required for CPB at normothermia should be 100 to 120 ml per kg per minute. The previous attempt by Dennis Gibbon Hemsworth failed because of the immense return to the heart via systemic pulmonary collaterals. However, only 65 to 70% of the venous oxygen was returning unused. Lelehai and colleagues showed that only flows of 8 to 14 ml per kg per minute were needed to maintain perfusion of the vital organs for 30 minutes at normothermia in canine experiments. Thus, they were able to clamp the venous inflow except the azygous vein. They immediately start perfusing at 20 to 25 ml per kg per minute comfortably in humans. Controlled cross circulation. Controlled referred as the use of pump, that is sigma motor, to control the flow of blood into and out of donor and patient. Cross circulation is achieved by suturing major arteries such as the carotid and femoral of partner and their corresponding veins to avoid excess pumping of blood from the organism with a high arterial pressure to that with a low one. The Soviet physicist VP Demiko proposed that only the heart of one partner be allowed to function in the joint circulatory system. The method has been improved to allow experiments to continue for several days, thus broadening the applicability of cross circulation in experimental biology and medicine. First surgical closure of VSD under controlled cross circulation in University of Minnesota on March 26, 1954 by Lillehei. VSD was successfully visualized by ventricular cardiotomy and closed in 12-month-old infant by direct suturing and bypass time of 19 minutes. Donor, who was patient's father, was lightly anesthetized with groin cannulation and serving as an extracorporeal oxygenator for kids. On the other hand, de Wall Lillehei developed bubble oxygenator in 1955. Initially, it failed due to air embolism, but he did large number of cases both on adult and children using the same oxygenator with less mortality. In 1956, Gott et al. Developed self-contained utilized plastic sheet oxygenator. In 1966, de Wall developed hard shell bubble oxygenator integrated with heat exchanger, which was disposable pre-sterilized polycarbonate unit. Development of oxygenator. Solid disk oxygenator, screen oxygenator, then solid disk with rotation screens, then bubble oxygenator and membrane oxygenator that is used these days in CPB circuit. It is of two types, silicon elastomers and microporous polypropylene. Polypropylene type has two types, a sheet type oxygenators and hollow fiber type oxygenators. Bubble oxygenator. The advantages of bubble oxygenator are easy to assemble, relatively small priming volume, deforming the frothy blood, and it has low cost. Disadvantages are microemboli formation, blood cell trauma, destruction of plasma proteins, excessive removal of carbon dioxide, and deforming capacity got exhausted. Now, microporous, that is polypropylene membrane oxygenator. Microporous polypropylene membrane oxygenator currently predominant design used for CPB. Micropores less than 1 micrometer in diameter, initially porous but plasma protein coating the membrane gas interface. Surface tension of blood prevents gas leakage into the blood phase. Conduit of oxygen and carbon dioxide exchange output. The only problem with this is plasma leakage and membrane wet at if used for a period of more than 24 hours. This is the modern CPB machine, sir. It has gas and vacuum lines, patient monitoring lines, gas blenders, vaporizer, inline monitoring lines, heater cooler unit, vent suctions and cardioplegia pumps, then venous cardiotomy reservoir, oxygenator and heat exchanger. Functions of CPB: diversion of blood from heart, oxygenation, elimination of carbon dioxide, systemic cooling and rewarming, circulation of blood, and non-physiological hypothermic hemodiluted non-pulsatile circulation. This is the CPB circuit. It is showing the arrangement of a typical cardiopulmonary bypass circuit using a membrane oxygenator with integral hard shell venous reservoir that is at the lower center and systemic heat exchanger and external cardiotomy reservoir. Venous cannulation is by cavoatrial cannula and arterial cannulation is in the ascending aorta. The systemic blood pump may be either roller or centrifugal type. The cardioplegia delivery system in the right side is a one-pass combination blood crystalloid type. The cooler heater water source may be operated to supply water to both the oxygenator and heat exchanger and cardioplegia delivery system. The air bubble detector sensor may be placed on the line between the venous reservoir and systemic pump, between the pump and membrane oxygenator inlet, or between the oxygenator outlet and arterial filters. One-way valve prevent retrograde flow. Other safety devices include an oxygen analyzer placed between the anesthetic vaporizers, gas inlet, and a reservoir level sensors attached to the housing of the hard shell venous reservoir. These are the equipments and the functions of CPB. Oxygenator system, venous reservoirs, oxygenator, heat exchanger. The function is oxygenate, remove carbon dioxide, and cool and rewarm the blood. Gas line and FiO2 blender deliver fresh gas to the oxygenator in a controlled mixture. Arterial pump pumps blood at a set flow rate to the patient. Cardiotomy suckers and vents scavenge blood from the operative field and vents the heart. Arterial line filters remove microaggregates and particulate matter more than 40 micrometer. Cardioplegia system deliver high dose potassium solution to arrest the heart and preserve the myocardium. Cannulas connect the patient to the extracorporeal circuit. Now venous cannulations. Venous cannulation and drainage. Principle of venous drainage. Traditionally accomplished by gravity siphonage. Renewed interest in applying suction to venous lines. Constraints of successful venous drainage. Venous reservoir should be below patient. Lines must be full to avoid airlock. Determinants of venous drainage. Central venous pressure influenced by intravascular volume and venous compliance. Excessive drainage may lead to vein wall collapse. Factors affecting venous drainages are gravity or suction pressure, systemic blood volume, vasoconstrictive drugs. Venous cannulas. There are different types of venous cannula, single stage or two stage cavoatrial cannulas, right angled single stage venous cannulas, single stage cannula with right angle metal tip made of flexible, it is made up of flexible plastic, often wire reinforced, size determined by the flow characteristics and patient need. Malleable single stage venous cannula. This construction allows the surgeon to shape and position the cannula to their specific needs while also allowing higher flow rates and minimal pressure differential. Silicone venous cannula with cuff. Silicone single stage cannula. Venous cannula with inflatable cuff in situ. This design maximizes venous drainage flow rates. Single stage basket tip cannula. Single stage venous cannula. Cannula with basket tip. This design maximizes venous drainage flow rates. Multi-stage venous cannulas. Two-stage venous cannula. It has wider portion with holes in the section designed to sit in the RA and a narrow tip designed to rest in the IVC. Three-stage venous cannula. Thin wall cannula designed to optimize vacuum or kinetically assisted venous drainage. These venous cannulas are typically the narrowest component of the CPV venous system and are therefore a limiting factor for venous drainage. Knowing the flow characteristics of the particular catheter, which should be provided by the manufacturer, established by benchtop testing, and the required flow, approximately 1/3 of the total flow from SVC and the 2/3 of total flow from IVC, one can select the appropriate venous cannula for a patient. A proper venous cannula will have a proper gradient of less than 30 millimeter of mercury and will not allow an excessive negative pressure to develop. The ideal venous pressure should be at or slightly above 0 millimeter of mercury. Venous cannulation establishment. The venous connection for CPB is accomplished by inserting cannulas into the RA. Three basic approaches are used: bicable, in which separate cannulas are inserted into the SVC and IVC; single atrial and cavo-atrial, that is the two-stage approach. It has wider proximal section with holes that lie with the RA and a narrower extension with end and side holes that extends into the IVC. Bicaval cannulation without caval tourniquets is often preferred for mitral valve surgery because the retraction that is necessary often distorts the cavo-atrial junction and interferes with the venous drainage if only a single atrial cannula is used. When bicaval cannulas are used, snares are frequently placed around the cannula. This forces all the venous return of the patient to pass to extracorporeal circuit, preventing any systemic venous blood from getting into the right heart and any air from getting into the venous line. This is sometimes referred to as a caval occlusion. Potential for venous air entry. Air entry through venous system can lead to systemic gaseous microemboli. Risks associated with air entry are micro air or foam formation, venous cannula site leaks, importance of airtight purse string sutures. SVC cannulation. An oval-shaped purse string is placed on the presenting surface of the SVC. Incision is made in the pericardial reflection over the right pulmonary artery on the medial side of the SVC and again lateral to the SVC. These incisions allow a right angle clamp to be passed easily around the SVC to grasp the tape and pull it through. The tape is placed in a rubber or plastic tourniquet. Alternatively, the SVC may be cannulated through a purse string in the right atrial appendage also. Peripheral extrathoracic venous cannulation used in emergency situation or minimally invasive surgeries. Femoral or iliac vein commonly accessed, guided by transesophageal echocardiography. Specialized cannulas are available for peripheral cannulations. Augmented venous drainage. Utilized regulated suction to overcome resistance. Method include kinetic pump or vacuum assisted drainage. Careful monitoring and regulation required for safe use. Complications associated with achieving venous drainage: atrial dysrhythmias, bleeding, and air embolization risk, malposition of cannula tip, and obstruction of catheters. Now, arterial cannulation. Introduction to arterial cannulation. Definition of arterial cannulation: insertion of a cannula into the ascending aorta for cardiopulmonary bypass during cardiac surgery. Importance of in cardiac surgery: facilitates establishment of CPB for cardiac procedures, allowing surgeons to operate on a motionless and bloodless field. Consideration for arterial cannulas. Design variations. Cannula come in different designs to suit specific surgical needs. Right angle tip, tapered shapes, and flanks aid in fixation and prevent excessive insertion length into the aorta. Importance of performance index. Descriptive characteristics indicating pressure gradient versus outer diameter at given flow rates. Help in selecting cannulas with optimal flow characteristics. Pressure gradient considerations. Pressure gradient exceeding 100 mm of mercury associated with adverse effects like hemolysis and protein denaturation. Optimal cannula selection aim to minimize pressure gradient. Risk associated with small cannulas. High flow through narrow cannulas may lead to adverse effects like high pressure gradient and turbulence. Jetting effect may damage the aortic wall and dislodge atheroemboli. Special purpose arterial cannulas. Overview of innovative cannulas. Introduction of specialized cannulas like dual stream and filter incorporating designs. Purpose of these cannulas in reducing cerebral embolization and improving selective cerebral cooling. So in the image you can see this Mackett dual lumen cannula, then venous ECMO cannulas, Medtronic Biomedicus arterial venous cannulas, Covident dual lumen cannulas. Connections to the patient ascending aorta, historical perspective, evolution of arterial inflow method from subclavian or femoral arteries to ascending aorta cannulation. Advantages of ascending aorta cannulation includes ease, safety, and avoiding additional incisions. Surgical techniques and consideration, importance of selecting cannulation site based on cannula type and aortic condition. Addressing atherosclerosis and complications, challenges of atherosclerosis, arterial cannulation site selection, to make proper strategies for modifying surgical approaches in the presence of atherosclerosis. Diagnostic method, importance of preoperative assessment techniques include on-table palpation of aorta thoroughly and epi-aortic ultrasonography can be done. Cannulation complications, management of complications, identification and management of common complications such as aortic dissection, malposition of cannula, and bleeding. Clinical presentations and diagnosis, signs and symptoms of aortic dissection during surgery can be seen. Diagnostic methods such as TEE and epiaortic ultrasound scanning can be done. Immediate management steps, cessation of CPB, recannulation distal to the dissection, and induction of deep hypothermia. Surgical approaches for repairing aortic dissection, including direct closure, patching, or graft replacement. Late complications are false aneurysm formation. Blood gas exchange device, oxygenators. Oxygen bubble oxygenators. The venous blood is passed up to vertical column through bubbles of oxygen are rising. Oxygen enters into the blood and releases carbon dioxide. Membrane oxygenator. True membrane oxygen made up of silicon, that is Metatronic 600 and 800, used in ECMO. Microporous membrane oxygenators made up of polypropylene, hollow fibers, and folded membrane lungs. Development of oxygenators, solid disk oxygenator, screen oxygenator, solid disk and with rotation screens, bubble oxygenator, membrane oxygenator, silicon elastomers, and microporous polypropylene. Why was bubble oxygenator placed before the pump? The simple design of bubble oxygenator relied on a hydrostatic pressure head from the patient to the mixing chamber connected by the venous line to the right atrium or vena cava. Generally, the pressure drop through bubble oxygenator is less than 30 centimeter of water, in contrast to the 100 centimeter of water pressure drops typically found in membrane oxygenators. Arterial pump technologies. The arterial pump is crucial in extracorporeal circulation, providing the energy necessary for systemic perfusion. Two main categories of arterial pump, displacement pumps and rotatory pumps. Displacement pump are roller pumps. Description: tubing inside a curved raceway with roller compressing the tubing to propel blood forward. Operations are roller in movements induces flow by squeezing blood through the tubing. Advantages are insensitive to load. Limitations are required careful calibration and periodic checks. Types of arterial pumps, rotatory pumps, that is centrifugal pump. Description: centrifugal pump operate on a principle of moving fluid by creating a pressure gradient between the inlet and the outlet that results from the creation of a vortex by rotation of the pump head. The rotating impeller spins 2000 to 5000 revolutions per minute, creates an area of low pressure in the center and an area of high pressure in the sides. Operation: blood enters in through an inlet and in accelerated by rotating impellers, then discharged through an outlet. Advantages are smooth surface, small priming volume, minimal area of stasis of turbulence. Limitations are susceptible to airlock, thus require vigilance. Ideal characteristics of blood pump: capacity to deliver flows up to 7 liters per minute against a pressure of 500 millimeter of mercury, non-damaging to blood components, smooth surface without area of stasis or turbulence, accurate and reproducible flow measurements, backup or manual mode of operation in case of power failure. Now, continuous inline monitoring. Continuous inline monitoring system use spectrophotometric optical fluorescence and reflectance-based system to continuously monitor up to 11 critical blood gas parameters with lab quality accuracy. Near real-time results are displayed and can be temperature corrected. Such systems have become a gold standard for continuous inline monitoring. A sensor is placed around the blood-filled tubings of the CPB circuit. They allow measurement of pH, PCO2, PO2, potassium, oxygen saturation, hematocrit, hemoglobin, and temperature. Although the initial cost of the monitor is high, they do not require the use of disposables and can be reused indefinitely. Frequent recalibrations can be done during uses if it is essential. Filters and bubble trap in CPB. Filters to reverse the hemodilution, the main use of the filtration is to reverse the hemodilution during CPB initiation on optimized perfusate hematocrit, raise colloid osmotic pressures, decrease post-CPB edema and weight gain, removes the vasoactive substance, that is complement system like C3A, C5A, TNF alpha, interleukin 1B, interleukin 6, interleukin 8, gross and microembolic gas, clumps of leukocytes and platelets, fat and other microparticles. And also for strategies to mitigate embolization include the use of micropore filters and bubble traps. Types of filter. Screen filters made of woven polymer thread with defined pore size function by interception, blocking particulate and air emboli, most commonly used in CPB circuit due to effectiveness in filtering various particles, include smaller pore size for pre-bypass filtration. Second is micropore filters in various locations, arterial line, cardiotomy reservoir, gas flow line to the oxygenated blood products, administration set, pre-bypass and cardioplegia delivery lines. Integration of micropore filters into cardiotomy reservoirs is common practice due to the effectiveness in reducing microemboli from suctioned blood. Integration of filters. Many cardiotomy reservoirs now include integrated micropore filters to reduce microemboli. Membrane oxygenators with integrated screen filters in the arterial line have shown effectiveness comparable to external arterial line filters. Roller pump operating in pulsatile mode may produce increased gaseous microbubbles, which can be reduced by membrane oxygenator with integrated filters. Bubble trap. Bubble trap is used to capture and remove air bubbles from the CPB circuit. Importance for maintaining optimal gas exchange and preventing air embolism. Integrated into a various components such as oxygenator and reservoirs. So in image A, it is conventional adult arterial line microfilter, and B is arterial line bubble trap. Novel approaches to arterial line filtration. Number one, computational fluid dynamic analysis utilized for numerical modeling to guide new filter design, offers insight into flow dynamics and potential filter efficacy. Ultrasound applications, that is EM blocker, method to divert microemboli away from cerebral vasculature using ultrasound on the ascending aorta. Demonstrates effectiveness in reducing cerebral microemboli signals in animal studies and pilot human studies. Dynamic bubble trap, device designed to reduce cerebral microembolization by capturing microbubbles in the flow line and returning them to the cardiotomy reservoir. Show to decrease microbubbles in the arterial line and improve cognitive outcomes in the clinical studies. Modified ultrafiltration. This technique has been adopted to be used post CPB. The MUF circuit is completely separate from the bypass machine. It is performed in order to concentrate the patient's circulating blood by removing excess water and also to salvage blood products from the circuit. Predominant use in pediatric cases. The ultrafilter is placed with the inlet connected to the arterial line and the outlet connected to the venous line. The normal arterial pump is simultaneously activated to deliver volume from the reservoir. MUF must be primed pre-pulmonary bypass and clamped off and isolated during the case. Leukocyte depleting filters. LD filters aim to reduce leukocyte activation and systemic inflammatory response during CPB. Clinical studies and findings. Studies have yielded mixed results regarding the effectiveness of LD filters in reducing organ injury and improving clinical outcomes. Impact on cardioplegia and surgical outcomes. LD filters used in blood cardioplegia have shown potential benefits in reducing reperfusion injury and improving early cardiac recovery. Mixed evidence exists regarding the impact of LD filters on duration of ventilation, ICU, and hospital length of stay and mortality. Venting the heart in cardiac surgery. Introduction. Venting the heart during cardiac surgery is crucial for maintaining optimal cardiac function and surgical exposure. Venting the right heart. The right heart is typically vented by venous cannulas to prevent distension and facilitate drainage. Source of blood to the right heart includes systemic venous return and coronary sinus drainage. Challenges arises with persistent LSVC and bicaval cannulation without venting. Venting the left heart, purpose and source of blood. Left ventricular venting aims to prevent distension, reduce myocardial remodeling, and facilitate surgical exposure. Abnormal sources include LSVC, patent ductus arteriosus, and aortic regurgitation. Indications for venting and left heart. Venting of left heart is indicated when the ventricle is unable to handle the returning blood volume. Common scenarios include cooling, ventricular fibrillation, aortic cross clamp, and cardioplegia administration. Monitoring left ventricular distension. Constant monitoring for left ventricular distension is essential during CPB. Methods include inspection, palpation, pulmonary artery catheter, and transesophageal echocardiography. TEE provides real-time visualization and is considered one of the best monitor for left heart distensions. Method of venting the left heart. Various techniques for left heart venting are available, include aortic root venting, direct venting, and pulmonary artery venting. Constant adjustments of suction level is crucial to prevent complications. Complications associated with left ventricular venting. Left ventricular venting associated with potential complications such as air embolism, bleeding, and myocardial injury. Strategies to minimize risk include proper vent insertion, use of one-way check valves, and careful monitoring. Excessive suction and improper function of the venting system should be avoided. Aortic root venting. Effective dearing of the aortic root is essential to prevent air embolism. Various techniques include stab wound, catheter vents, and dual vent strategies can be followed. Verification of dearing effectiveness can be achieved through transesophageal echocardiography. Cardioplegia delivery system. Cardioplegia delivery is essential during cardiac surgery to induce cardiac arrest and provide myocardial protection. This presentation discusses the methods. Cardioplegia is administered to induce myocardial arrest and provide myocardial protection during cardiac surgery. Traditional methods like topical hypothermia have been replaced by cardioplegia solution containing potassium. Cardioplegia may be delivered antegrade into the aortic root or coronary ostia or retrograde into the coronary sinus. Components of cardioplegia delivery system. Cardioplegia delivery system consists of pump, typically roller pump, heat exchangers, bubble traps with microfilters, and monitoring ports. Recirculating and non-recirculating systems are commonly used, with commercially available disposable system being preferred. Types of cardioplegia systems. Recirculating cardioplegia system. In a recirculating system, cardioplegia fluid is stored in a reservoir bag and delivered to the surgical field via pump and heat exchanger. A switching device directs the fluid either into the cardioplegia cannula or back to the reservoir for recirculation. Non-recirculating cardioplegia system is in the lack of the recirculation line. Blood cardioplegia is administered by mixing blood and crystalloids in a single tube before delivery to the patient. Microplegia technique. Microplegia technique involves infusing small volume of highly concentrated cardioplegia solution into the coronaries. It reduces the amount of crystalloid administration and has been associated with a lower incidence of post-operative complications. Types of cardioplegia administration: antegrade administration and retrograde administration. Antegrade cardioplegia can be administered into the aortic root or directly into the coronary ostia. Monitoring aortic root pressure during administration is crucial to ensure adequate myocardial perfusion. Retrograde cardioplegia is administered into the coronary sinus. Special cannulas with cuff or balloons are used to prevent back leakage and ensure optimal delivery to the myocardium. Ostial and vein graft also can be used to deliver cardioplegia. Ostial cardioplegia administration is directly delivered into coronary ostia, delivered by handheld cardioplegia cannulas, and vein grafts are cardioplegia directly delivered into the proximal end of vein grafts, providing flow distal to the blockages, delivered via small vein cannulas hooked up to the vein proximal end. Consideration and monitoring. Proper cooling and electrical arrest should be observed promptly after cardioplegia induction. Monitoring of pressure, flow rate, and temperature is essential to ensure effective myocardial protection. Types of cardioplegia: straight crystalloid solution and blood cardioplegia. Pre-made solution with electrolytes and buffer. Example, St. Thomas solution or Plegisol. Additional potassium can be added if desired. Can be delivered as straight crystalloid. Blood cardioplegia are more common. Usually crystalloid solution mixed in a ratio with pump bloods in four parts blood and 1 part crystalloid. Crystalloid cardioplegia. These solutions contain minimal amount, 0.6 ml per 100 ml at a PO2s of 100 millimeter of mercury at a temperature of 10 degrees Celsius of dissolved oxygen, whereas the myocardium consumes only 0.33 ml of oxygen per 100 gram at 15 degrees Celsius. Because even a short period of ischemia results in the gradual accumulation of oxygen depth. Moderate to severe myocardial hypothermia is necessary to prevent the rapid degradation of energy stores. To overcome the oxygen deficit issue, oxygenation of crystalloid cardioplegia has been clinically used and has demonstrated a decrease in creatinine kinase MB levels. Disadvantages of crystalloid cardioplegia: extensive rewarming period, which may exist 30 to 45 minutes, slow recovery of myocardial metabolism, poor response to postoperative hemodynamic stress, and gradual accumulation of blood depth and myocardial damage if adequate hypothermia are not maintained. Blood cardioplegia: advantage: optimum oxygenation superior to oxygenated crystalloids, better removal of carbon dioxide, buffering action and reducing agent, presence of colloid avoidance avoids adverse oncotic pressure gradient, presence of oxygen free radical scavengers, presence microvascular response compared with crystalloid cardioplegia. Concerns: the hypothermia shift to the left of the oxyhemoglobin dissociation curve, thereby reducing the release of oxygen at the tissue level. The experimental evidence that blood cardioplasia may not protect the myocardium at low temperatures. The potential of hypothermia induce sludging and red cell role formation. Phases of myocardial protection. There are 4 phases of myocardial protection in cardiac surgery: pre-treatment, induction, maintenance, and reanimation. Pre-treatment phase includes ischemic and pharmacologic preconditioning, include volatile anesthetic agents or propofol, which exert protection at the cellular and mitochondrial levels. Induction phase is intended to not only arrest the heart and reduce myocardial temperature, but is also an opportunity to resuscitate the heart that is energy depleted or failing. Warm induction is an example of a therapeutic role of induction phase. Maintenance phase. This phase is during arrest, in which gives an opportunity to reoxygenate and restore nutrients to the myocardium, wash out metabolic byproducts, and restore ionic balance to the myocardium. Maintenance can be achieved by intermittent infusion of solution, for example, every 20 to 30 minutes, or continuous infusion, usually in a retrograde mode. The reperfusion and reamination period at the time of declamping, that is 5 to 10 minutes interval, to remove or lessen the thermal gradient between the cold heart and the warm systemic blood, establish ionic hemostasis, increase the aerobic metabolic capacity after suppression by hypothermia, repolarize the heart if hyperkalemia depolarizing arrest is used, and to deliver drugs that work specifically at reperfusion. Systemic inflammatory response syndrome on CPB. SIRS. A definition: SIRS is a host response characterized by clinical manifestations such as fever, tachycardia, tachypnea, and leukocytosis. The criteria for diagnosing SIRS include parameters such as body temperature, heart rate, respiratory rate, and leukocyte count. Systemic inflammatory response after cardiopulmonary bypass, that is SIRAB. CPB induces a whole body inflammatory response, often referred to as a SIRAB, which includes both infectious and non-infectious component. Differentiating between inflammatory response due to surgery and that due to CPB presents challenges. Initiating factors of SIRAB. Various factors contribute to the initiation of SIRAB, include microemboli formation, disruption of hemostasis, and cytokine-mediated events. Contact of blood with the foreign surface of the extracorporeal circuit is a primary contributor to the inflammatory response. Factors contributing to inflammatory response. In addition to blood contacting surface, factors such as altered arterial blood flow patterns, shear stress, tissue ischemia, reperfusion, hypothermia, and heparin play significant role. These factors lead to activation of inflammatory cascades and the release of inflammatory mediators. Contact activation cascade. The contact activation cascade is initiated upon exposure of blood to the non-endothelialized surface of the CPB machine. Protein involved in this cascade include coagulation factor, factor is 12 and factor 11, precalciferin, and high molecular weight kininogens. Inflammatory mediator release. Activation of contact activation cascade lead to release of inflammatory mediators, including bradykinin, plasmin, and components of complement cascade. These mediators contribute to endothelial activation and neutrophil mediated injury. Prolonged inflammatory response. The inflammatory response initiated by CPB can persist even after discontinuation of bypass, depending on its magnitude. Prolonged inflammation may contribute to postoperative complications and adverse outcomes. Operative renal risk factors and operative assessment of renal function. Introduction. Renal dysfunction following CPB is a significant concern, with AKI development ranging from 1.2% to 13%, depending on preoperative estimate GFR. AKI and AKID substantially increase mortality risk and post-cardiac surgery. Intraoperative renal risk factor. Intraoperative factors contributing to renal dysfunction include low cardiac output, decreased effective arterial blood volume, prolonged CPB times, that is more than 130 to 180 minutes, systemic inflammatory response syndrome, inappropriate hemodilution, and embolic phenomena. Interventions to mitigate renal risk. Leukodepletion during CPB reduce marker of renal injury and incidence of AKID. Aproteinin, despite initial support of renoprotection, has been associated with increased risk of AKID. Hematocrit level during hemodilution may influence AKID risk. Optimal ranges need further investigations. Impact of thoracoabdominal aortic surgery. Thoracoabdominal aortic surgery poses significant risk of AKI, with over 50% of patients experiencing AKI. Factors contributing to renal dysfunction include aortic cross-clamp duration and intraoperative blood loss. Mortality rates for AKID post-surgery remains high. Influence of anesthetic agents. Sevoflurane, a fluorinated anesthetic, had debated nephrotoxicity due to free fluoride ion release. Clinical data suggests no significant renal dysfunction with sevoflurane used during cardiac surgery. Experimental data indicate potential renal protective effects of sevoflurane. Perioperative assessment of renal function. Perioperative assessment focus on urinary output with oliguria defined as less than 0.25 to 0.33 ml per kg per hour. Hourly urine output volume measurement help detect renal hypoperfusion, but oliguria may not predict postoperative AKI. Oliguria does not always indicate impending AKI. Non-oliguric AKI is more common. Principles of CPB. Hypothermia, hemodilution, ultrafiltration, and anticoagulation. Hypothermia. Feasibility and applicability of hypothermia for heart surgery was first suggested by Bigelow and colleagues in 1950. Rationale: provide organ protection and safety margin during CPB, decrease metabolic rate and oxygen consumption, preserve high energy PO2 stores, and reduce excitatory neurotransmitter release. Lower pump flow suffice, decreased return, improves visibility, and less blood trauma. Better myocardial protection, safety margins in equipment failure. Effect of hypothermia on myocardium. Basal myocardium oxygen requirement is 10 ml per kg per minute. In the systolic state, this goes down to 0.1 ml per kg per 100 gram per minute. For every 10-degree drop in temperature, there is an additional 50% decrease in oxygen requirement. However, there is a potential for myocardial damage below 10 degrees due to damage to the membrane enzymes responsible for cellular integrity. Therefore, target myocardial temperature are usually 10 to 15 degrees. Effect of hypothermia. Reduces heart rate, increases contractility, increases dysrhythmia, coronary blood flow preserved. Lungs, progressive decrease in ventilation. Gas exchange is unchanged. In kidney, decrease in renal blood flow, reduces concentrating ability and glycosuria. In liver, decreases in metabolic and excretory function and leads to marked hyperglycemia. In blood vessels, vasoconstriction, skeletal muscle, and in extremities. In blood products, increases in blood viscosity, RBC aggregation, portal platelet sequestration, complement activation, and catecholamine release and bradykinin release. In brain, with a linear decrease in blood flow, CMRO2 decreases exponentially. At normothermia, cerebral blood flow is to CMRO2 of ratio is 20:1, which changes to 75:1 at deep hypothermia. Acid-base management in hypothermia. Acid-base alteration with temperature change. Normal pH and PCO2 values vary with temperature. The blood perfusing different tissue experiences pH and PCO2 changes due to temperature variation. Solubility of gases in liquid changes with temperature affecting PCO2. pH changes with temperature independently of CO2 content. pH regulation strategies, alpha versus pH stat. Alpha stat maintains constant net charge of proteins with temperature changes. pH stat maintains constant pH at varying temperature. Alpha stat strategy preserves intracellular electrochemical neutrality. pH stat requires added carbon dioxide to maintain constant PaCO2 and pH during cooling. Alpha stat has less but adequate cerebral blood flow, better cerebral recovery, cerebral autoregulations are preserved, less arrhythmias, and it is used in adult. It is better used in adults. pH stat is increased cerebral blood flow, global cerebral cooling, better flow to deep brain structures, increased risk microemboli, cerebral edema, tip redistribution away from the marginally perfused area, and it is better used in children. Pulsatile versus non-pulsatile flows. Historical context: early pumps deliver non-pulsatile flow due to technological limitation. Technological advance now enable the delivery of intermittent high amplitude pressure and flow pulses during bypass. Benefits of pulsatile flow: improved major organ blood flow and oxygen delivery at the tissue level. Potential advantages of in pulmonary function, renal function, and maintenance of glomerular filtration. Studies suggest benefits such as shorter ICU and hospital stays, reduced need for inotropic supports, and lower lactate concentration. Drawbacks and controversies are increased complexity of CPB circuit, potential for red blood cell and platelet damage, conflicting results regarding the impact on microcirculation, lack of precise definition, quantification of pulsatility in research studies. Anticoagulations on CPB. Heparin, the most commonly used anticoagulation drug on CPB. Heterogeneous mixture of molecules from 3,000 to 40,000 Daltons. Mean is 15,000. Batch to batch heparin preparation may have different activity levels per milligram. Standardized activity levels reported in units, that is 100 units. 1 mg is 1 unit will remain anticoagulation of 1 ml of recalcified sheep serum for 1 hour. Heparin acts as a catalyst for antithrombin 3 to accelerate the neutralization of thrombin factor 10A, factor 9A, factor 11A, 12A, 7A, and tissue factor complexes. Dose during CPB. Initial dose for 200 to 400 international unit per kg. Off pump CABG dose is 200 international unit per kg. On pump CABG as 300 to 400 international unit per kg. For cyanotic heart disease, it is 400 international unit per kg. Maintenance dose is 50 to 100 units per kg, administered anywhere between 30 minutes to 2 hours. The extracorporeal circulation was primed with bank blood that was heparinized in the dose of 2,500 to 5,000 units per unit of blood. Monitoring of heparin effect. The anticoagulation effect of heparin should be monitored functionally before instituting CPB by activated clotting time. The administration of heparin does not guarantee that all patients will be adequately anticoagulated because there are differences in levels of circulating cofactors and inhibitors that can alter the pharmacokinetics and pharmacodynamics of the drug. Activated clotting time. Functional tests of heparin activity are related to the whole blood clotting time. The whole blood clotting time requires that whole blood placed in a glass tube maintained at 37 degrees Celsius and manually tilted until blood fluidity was no longer detected. Glass tube containing diatomaceous earth, that is salite, kaolin, or a combination of activators. The presence of an activator augments the contact activation phase of coagulation, which stimulates the intrinsic coagulation pathway. Detection of ACT values can be performed manually, but is more commonly by automated methods and in hemochrome and hemotech system. Uh, this is automated hemochrone and this is automated hemotech. Blood required here is 2 ml and here it's 0.4 ml. Activator is salite and in hemotech the activator is kaolin. ACT monitoring. Bull et al. In 1975 recommended structured approach using ACT monitoring. They adopted ACT of more than 480 seconds as safe value on CPB. ACT below 180 seconds is considered as life-threatening. Current practice. Gravely et al. Have selected following CPB heparin management protocol. Administer heparin 300 units per kg IV. Draw an arterial sample for ACT in 3 to 5 minutes. Give additional heparin to achieve ACT of more than 300 seconds during normothermia CPB and more than 400 seconds for hypothermic, more than, that is less than 30 degrees Celsius. Prime extracorporeal circuits with 3 units per ml heparin. Monitor ACT every 30 minutes during CPB. If ACT decreases below desired minimum value, dose of 50 to 100 units per kg can be given. Heparin resistance. Heparin resistance is documented by an inability to raise the ACT to expected level despite an adequate dose and plasma concentration of heparin. Clinical conditions associated with heparin resistance. Familial 83 deficiency, ongoing heparin therapy, extreme thrombocytosis, more than 7 lakhs per mm, and septicemia. Adverse effect of heparin. Bleeding, deep vein thrombosis, heparin-induced hyperkalemia, heparin-induced thrombocytopenia. It develops 7 to 14 days after initiation of heparin, but may develop within 1 to 2 days in patients with previous exposure to heparin. It is likely to be immune-mediated, antibody formed against platelet factor 4 and heparin complex. Protamine. It is heparin antagonist, a low molecular weight alkaline protein that is rich in arginine. It is used to neutralize heparin on CPB. Mechanism of action, since it is highly cationic peptide, so binds to heparin and low molecular weight heparin to form a stable ion pair which does not have any anticoagulation activity. This complex is later cleared out by reticuloendothelial system. Heparin reversal dose is 1 to 1.3 mg for each 100 international unit of heparin. Protamine reactions. Since protamine is derived from salmon fish sperm, so patients have a high risk of anaphylactic reactions. Patient at risk, allergies to shellfish, prior exposure to protamine, patients on NPH insulin. Types of protamine reaction. Type 1 is hypotension related to the fast administration of protamine. Type 2 is anaphylactic reaction resulting in decreased SVR, bronchospasm, and edema. And type 3 is pulmonary vasoconstriction, RV distension, PA hypertension, decreased LV filling, and systemic hypotension. It's the severe type. Now, non-cardiac use of cardiopulmonary bypass. In thoracic surgery, surgery of the great vessels, pulmonary embolectomy and arctectomy, tracheobronchial reconstruction, resection of mediastinal tumors, lung transplantation, and retrotracheal goiter. Abdominal in abdominal surgeries, resection of renal tumors with IVC extensions, and then in neurological surgeries, arteriovenous malformations surgery, and basilar artery aneurysm surgeries. And it is also used for resuscitation, that is accidental hypothermia or hemodynamically unstable patient transfer. Thank you, sir.
Thank you, Chavi. But this was a very extensive lecture, including everything in one lecture.
Yes, sir.
Because it became a little hodgepodge, if I may say so.
Yes, sir.
First of all, basically, you should have talked or this thing about more of the basic concept of the bypass.
Okay, sir.
Requirements. What is partial CPB? What is total CPB? How do you
Yes,
calculate
sir.
flow? How do you maintain circulatory hematocrit? What are the priming solutions? How much
Yes, sir.
temperature you go down to? And these are more important. These are more important practical aspects rather than going on to things. They are all specialized things. They are ultrafiltration and then various other leukocyte filtration and other things are all subsequent additions. We should have talked about a little bit about the different types of pump, roller pump and centrifugal pump. What are the pros and cons of them? We
Okay,
should have
sir.
talked about the bubble and the membrane oxygenator. Of course, nowadays we don't use bubble oxygenator. Where is the
Yes,
bubble
sir.
oxygenator? Before the pump or after the pump? Why is it so? And similarly, the membrane oxygenator. These are few things, that the basic things that you should know. And then of course the temperature, how
Yes,
much
sir.
you go down, and the cooling rate and the rewarming rate is very important in the metabolism of the patient. So how fast can you cool, and how slow do you have to come out rewarming? These are all aspects that have to be mentioned. So first of all,
Yes, sir.
maybe you should have split this lecture into a couple of things. The basics and then the specialized aspects. And most important thing is you did not mention anything about the emergencies in CPP, like airlock in the venous line, air in the arterial line, what happens to air embolism, how do you manage those? These are very important things that on CPB, which can happen in any case. Okay, so
Yes, sir.
so this is this thing, because you try to mix or fit in everything in one lecture, which is totally impossible
Yes, sir.
actually.
Yes, sir.
So
Yes, sir. That's fine. Yes,
we
sir.
split them into different aspects, and maybe Prakash can tell us. Thank you, Prakash, for attending. So you can give us some idea how to go about these things.
Yeah, good morning, sir. Sir, I found it quite good, sir. It was a summary of the whole overview of cardiopulmonary bypass. Only thing is, I could have included my students for this. I got to know yesterday night. Sir, next time onwards, if you tell me before, I can include my students. It was for a complete summary of a CPB. This presentation was quite good, sir. As you said, it had a lot of this thing, so we can split it into 3 or 4 topics on CPB. That will be
Yes, sir.
wonderful.
Yes, sir. Sure, sir.
Like history of CPB as separate, because my
Yes, sir.
students also have a syllabus of that. Then myocardial protection are separate, and emergencies in CPB are separate like that. But
Yes, sir.
if you see overall, sir, I liked the presentation, sir. It had this thing of everything, somebody, and it would have been very useful for my students and team, sir. That is my comments.
We can ask Chavi to share her presentation.
Yes, sir.
Yes, sir.
I'll ask Dr. Chavi to share it, and we will have it, sir. Next time, you please inform me earlier, sir. I will
Yes, sir. Sure,
include
sir.
my students. Yeah.
I'll inform, sir. Yes.
Thank you. Because the many students are there, even African students are there who have come for a training, and it would have been very useful for all of these people.
Maybe next time we should talk about myocardial protection as a separate thing, and then
Yes,
the
sir.
concept of
Sir.
hypothermia, deep circulatory hypothermia as a
Yes,
separate
sir.
thing, which along with
Yes, sir.
cerebral
Yes, sir.
protection and
Yes, sir.
spinal cord protection, and the third thing is emergencies in CPB. These are
Yes,
two
Yes,
sir.
sir.
things that
Sure,
are
sir.
important.
I'll make separate presentation, sir, and then I'll present.
Sir, you got anything
And
to
we
say?
can help you with the slides also, Dr. Chabi. Anything you
Yes.
want, you please. I have, because we are taking classes, we can always
sir.
help you. All these
Okay, sir.
topics are separately available with me.
Yes, sir.
If you
Okay,
want,
sir.
you can share that and make
I'll
your
get back to you. Yes, sir.
Yes.
Yes, sir. Sure, sir. Sure, sir.
That's the reason we wanted you to come to this lecture.
Sure, sir. I will attend, sir. You please. I have given it to Srikanth and so many other senior professionals also. I shared it with some of the students also today, but they complained they couldn't enter. Maybe you didn't know the names and the guest allowing was restricted or what. I didn't know.
There is no
sir.
restriction for anybody
No
to learn.
restriction is there, sir.
Okay, ma'am.
You can
No,
join, sir.
some students from this Tanzania and Rwanda told they couldn't enter like that. Then I told that just enter as a guest, you can come in. Otherwise, next time we can always allow you.
Yes, sir. Sure, sir.
Jairaj, sir, you have got some comments?
No, very good presentation,
Thank you,
but
sir.
too extensive, and brought in our myocardial protection and other things, which actually should be confined to what are the latest things in cardiopulmonary perfusion.
Yes, sir.
You didn't say anything about the coated surfaces, the heparin or phosphorylcholine coated tubing and the oxygenator, so that the amount of heparin used is reduced. And you didn't say anything about the how to reduce the priming, the mini priming and other things. And also you didn't say anything about the retrograde priming and the rapid antigrade priming displacement. These are the new
Yes, sir.
things which tries to reduce the priming volume as much as possible. I'm sure
Sure, sir.
Prakash will explain much more than me.
Okay, sir.
The idea is that in adults, when you use only clear prime, the hematocrit falls,
Yes,
Ideally,
sir.
in this hospital, we want to keep the hematocrit in adults between
Yes,
21
sir.
and probably 24, and in children 30 or above that, So
Yes,
it's very important to measure what are the things to reduce the planning, and also because normal venous drainage is gravity dependent. So
Yes, sir.
if the patient and the table are very high and the reservoirs are much below, so there's a longer tube. So some of the other things they have mentioned is that rapid antigrade planning and also uh, vacuum assisted, so that in vacuum assisted thing, the table and the reservoir, everything can be at the same level, so the
Mm.
tubing is good and so all those things should have come, little bit.
Yes, sir. Yes, sir. I'll make, sir, separate topic presentations I'll make, and then I'll present in detail, sir.
Recent advances, if you look into any of the recent advances in CP bypass, it's what you find.
Yes. Okay, sir.
Basically, you should have done what you
Because when you do for ECMO and all, you want to reduce the heparin use as much as
Yes, sir.
possible.
Yes, sir.
The importance of coated servers and
yeah, as Prakash said, as an overview, just as this thing, it was okay, but everything in one, you cannot say the whole of cardiopulmonary bypass in 1 hour.
Yes, sir.
So you
So
get
it
a
was
good
just basics, sir. That's
correct.
I'll
No,
make, sir,
basic.
separate, sir, presentations on each topic, and I'll present, sir.
No, because
myocardial protection is entirely
Is
different.
entire topic, yes, sir. Sorry.
if you get a question on CPB in your exam, you can't write all this in one answer. They will never give you a full thing in one answer. So there are different aspects, like your as we discussed, emergency, recent advances are separate, emergency
Yes, sir.
separate.
Yes, sir.
And something more on the
CPB itself is a separate topic.
and some more on the inline monitoring about the
Yes, sir.
balance.
Yes, sir. Those I actually made just brief like slides on that because,
You made a part of
sir.
it.
Yes,
Actually,
sir.
these 11 parameters can be monitored.
Yes, sir.
Okay. Anyway, it's a good attempt. Thank you.
Thank you, sir.
And also that's theory, and most practically, what are the things we monitor in our hospital?
Yes, sir. I'll add, sir. Yes. Sure, sir.
My favorite